Hello, everyone. I'm Hartford Healthcare's Tina Verona. Thank you so much for joining us for this live Facebook discussion. Well, November is literally just a couple of days away, and it is Epilepsy Awareness Month. So I'm so happy to be joined by Dr. Gabriel Martz. He's Director of Epilepsy at the Hartford Healthcare Eye Neuroscience Institute. So happy to have you here with us tonight.
My pleasure.
Yeah, so we want to create, obviously November is Epilepsy Awareness Month. It's all about creating awareness for epilepsy. And then very fitting, tomorrow's Halloween, and there's something called the purple pumpkin that has to do with epilepsy. So let's first talk about the purple pumpkin and what that means.
Yeah, the purple pumpkin is really just meant to catch your eye and spark people to ask, why is your pumpkin purple? And someone will then talk to you about epilepsy in some form or other. And that's really meant to just show you that people with epilepsy are just people like any other. And we often think of seizures as being scary events, and they are scary for people to go through and for people to see loved ones go through. But people with epilepsy who have seizures are just people, and we want people to start understanding that there's not anything necessarily wrong with them other than having seizures.
And for that very reason, there is somewhat of a stigma attached to that, because some people don't want to come forward, and they may have a seizure or two a year and say, oh, I'll just deal with it, and not come forward. And I think that's really the purple pumpkin, and the awareness part of it is to say you can come forward. There is help out there to help with seizures. So let's talk about that.
Yeah, I mean, the people who you see with seizures are the ones who are having seizures frequently. Mm-hmm. So that's often the people who are having the hardest time controlling their seizures. There's lots of folks with epilepsy who have well-controlled seizures, and you don't know they have epilepsy because just like anyone else, they go to work, they come home, they raise kids, and they're doing life as anyone else is. But the folks who can't hide that, those are the ones we see more often. And a lot of times, those folks are less likely to be married, to have jobs. They're much less likely to be able to drive. They're much less likely to go to college. So all these things really impact their lives, and that's even if they're only having, let's say, 3 or 4 seizures a year. So if a seizure lasts 1 or 2 minutes, you've got about 10 minutes a year of seizures, you can't drive. So that's a really big impact on your life for just a few minutes out of the year. So what we're trying to do is make people realize that if you're having any seizures at all, and you've been trying various medicines and they're just not getting your seizures better, there are other treatments available to you. At Hartford Healthcare, we have a whole variety of care providers, from doctors to social workers to psychiatrists, who are all focused on trying to get people's lives better. And in many cases, that means trying to stop seizures. We have a whole pathway towards making sure the diagnosis is correct, making sure it's a very specific diagnosis, and finding the best treatments for any individual human being who we're caring for. That might mean changing medications. It might mean doing a workup for surgery to try to remove the part of the brain that's causing seizures, which sounds scary, but we're very careful about that. The other things that we look at are just quality of life in general. Just because someone has a few seizures a year doesn't mean they can't go to college with the right support or get a job or have children. So we also try to look at what their goals are and help them achieve those goals with or without seizures.
So if a person is having a couple of seizures a year and they choose to just really not do anything about it, does that increase? Can it become worse? Can it become dangerous?
Well, the seizures themselves have some danger depending on the environment. The most dangerous piece of most seizures is where someone is when they have a seizure. So if you're in an unsafe environment, like driving, for example, it can certainly cause a lot of harm. It's unclear whether continuing to have seizures makes seizures worse. That's been a question for decades, and it's been studied in all kinds of ways. It's just a very tricky thing to answer. So I don't have a best answer to that question, although it's a great question. I wish we did. What was your other question?
Well, I was just saying, like, if people, I think that's the importance of having specialists like yourself here, and not just at Hartford Hospital, but really throughout the state. And as we go along the months here, that we'll be opening up additional centers to treat epilepsy patients. And is it something like 90,000 people here in Connecticut with epilepsy?
Yeah, I'll be on the safe side and say 60,000, but by some numbers it would be up to 90,000 people, and that's a lot of people. So, and recognizing, as we've been saying, that it may be transportation limited, we have a large group of providers that are specially trained in epilepsy. We are based out of Hartford, but we are now making a great effort to come to you. So we have a clinic that opened opens next week in Southington. We have a clinic that opened a couple weeks ago with a provider seeing patients in Torrington, and we're very soon going to be in Norwich as well. So we're trying to expand throughout the state and provide care where patients live, because we realize that you can't always get to us.
Absolutely. And if you can get to us here at Hartford Hospital, there is that 24-hour monitoring unit for folks to come in, where you actually monitor any seizure-type activity and as it's happening. Take us through that monitoring unit here at Hartford Hospital.
The first step in, just to take one step back, the first step in diagnosing is talking to the patient and getting a very good sense of what kind of seizures they're experiencing and how it's impacting them. And then we use testing in the outpatient environment, like imaging of the brain and MRI, or an outpatient EEG. And if those things give us enough information and we've gotten the patient to really be doing well, then great. But in many cases, about a third of people with epilepsy, they're not going to be well controlled by medicines. And some people who are told they have epilepsy actually don't have epilepsy, which of course means medicines aren't going to work because it's not epilepsy. So in that case, we do often request that the patient come into the hospital in our specialized unit called the EMU, or the Epilepsy Monitoring Unit. And in that unit, we have EEG that runs continuously. We have video that's run continuously, and we have a large group of nurses and EEG techs and other staff who are very highly trained to care for people with seizures. So the goal of coming in the hospital is to have seizures, which is tricky for people because you spend your whole life not wanting to have a seizure, but you come in the hospital, we want you to have a seizure. But the value of that is if we can see your seizure or your event, we can tell you for sure whether it is epilepsy, if it is epilepsy, what kind of epilepsy, and that opens the door to treatments other than just the same medicines you've been trying all this time. We can decide whether surgery would be a good option for you or not. We can decide if there's other medicines you haven't heard of that are a little bit less commonly used that might be much better for you. There's a lot of information that's gained by the patients and family, to a lot of understanding. When people leave the hospital, they generally feel like they understand their brains a lot better, actually.
Is there a genetic component to epilepsy, to people being diagnosed with epilepsy?
There is a genetic component. That's a great way to say it. There are, if you look at all the people who have epilepsy, if you're talking about those who have a specific gene, one gene that has caused their epilepsy, that's a very small percentage overall. There's a lot of different genes that can cause epilepsy. So if you start looking at all the genes that might cause epilepsy, it's a slightly larger group, but still overall a very small number. That's partly because we haven't identified all the genes yet. I'm sure there's other genes that will come every month and every year. We're getting many more genes identified. But it's also because it's not, for most people, not purely a single gene causing it. For most people, we suspect there's a genetic predisposition, meaning that there's something about their genes and the way they were made, where over time, with exposures to things like viruses in the environment, eventually their brain learns how to make seizures. And we don't fully understand that process. We know that people who have epilepsy, their family members have a higher chance of having epilepsy, but not a very high chance overall. It's a little higher than the general population.
Is there any correlation between epilepsy and stroke?
There's a correlation in the sense that any brain injury can cause the brain to heal in a way that enables seizures to happen. And that can be a traumatic injury, can be a hemorrhage, or a stroke. So a stroke being not enough blood flow to one part of the brain, causing part of the brain to die. The area of the brain that is not dead but was injured by lack of blood flow can heal in a way that enables it to cause epilepsy. So what we see, if you look at the age range of people who start to have seizures and start to have new onset epilepsy, when you get above age 50 or 60, the most common causes of epilepsy at that point are stroke and brain tumors.
Mm-hmm. And are you seeing, when we talk about epilepsy, what is sort of the trend that you're seeing? Are we seeing it, you hear of it more in the older population, but are we seeing it in the younger population more and more? And what kind of is that age range? Does it really kind of run the gamut there?
Yeah, running the gamut is exactly right. From age 0 or even pre-birth in some cases to end of life. We see epilepsy can start at any time during that age range. And what causes epilepsy changes with age. So as a young child just being born, it can be something traumatic about the birth, a very difficult labor. It can be an infection that the mother had unfortunately during pregnancy. It can be a genetic problem that was obviously even before birth. And then as kids age into their childhood, we see other what's called epileptic encephalopathies come on. Some of these are genetic. Other of these can be caused by, we think, by viruses and the body's response to viruses. And then that continues on through young adulthood. And if you look at the teenage to sort of young adult age range, just like in almost everything else, the high incidence events are traumatic people who have car accidents or sports injuries, things like that. So with a significant enough brain injury, you can start to see epilepsy, but there's any other number of causes at that age range as well that continue all the way through adulthood.
Particularly in younger patients who have seizures, and their brain is still developing, can they, as they grow into adulthood, can those seizures sort of correct themselves as the brain continues to develop? Can that just go away?
A lot of people call that outgrowing epilepsy or growing out of epilepsy, and that does happen. If you think of all the changes that occur in your body as you go from age, say 3 years old all the way up to age 20 or so, similar changes are happening in the brain, and the brain uses different kinds of proteins that are on the cell surface or the neuron in the brain, and those proteins have the main job is to let the neuron fire its action potential when it is intended to do so, and then not fire when it is not supposed to do so. And that set point or that trigger has to be extremely highly controlled. And so the proteins that do that when you're a young child are different than the proteins that your brain uses when you're an adolescent, and different than when you're an adult. And it may be that someone has a particular genetic abnormality in one particular protein that is only used, let's say, from age 5 to 10. So that by up till age 5, no epilepsy. Between age 5 and 10, when that protein is being used in the brain, there is seizures and epilepsy. But by age 10, when you've replaced that protein with a normal genetic protein, epilepsy goes away. So that's how we theorize what's happening when people outgrow epilepsy. That's why we think that when people are in their late teenage years or early 20s, by then you're using most of your adult set of proteins in the brain, and it's unlikely from that point on that you'd outgrow epilepsy. It's a very common question. Someone who has 1 or 2 seizures, and by the time they've met us and we've got them on meds and they're not having seizures, they'll often ask, and I think it's a fair question, do I still need to take this medicine?
Yeah.
And we have that discussion frequently. Unfortunately, depending on the type of epilepsy that it is, most cases in adulthood will not just go away. Mm-hmm. However, on the flip side, most cases will be well controlled on medicines, and our job is to work with you to find medicines that don't bother you and that you can take for a long time and feel fine.
In case you're just joining us, we're talking to Dr. Gabriel Martz. He's Director of Epilepsy here at the Hartford Healthcare Eye Neuroscience Institute. If you suffer from seizures or know of somebody who does or have epilepsy, we do invite you to ask him a question, anything you want, while we have him here for a few minutes. Dr. Martz, what happens when medications no longer work for a patient?
And we see that in about 1/3 of people with epilepsy. And we spend a lot of time with that particular population because, of course, they're sick, having a lot of seizures. So what we want to find, if possible, is a way to do a surgery that will help to cure them of epilepsy. Mm-hmm. What the numbers show is that someone who's had 2 medicines tried and is still having seizures has about a 5% chance or less of ever controlling their seizures on medicines. So by the time you get to your 3rd, 4th, 5th medicine that you've tried, those numbers continue to go down. So a lot of people in our clinics have about a 1% chance of ever stopping their seizures with a medicine, which is why we start thinking immediately, even if we haven't mentioned it right off the bat, about a surgical option, because there are many people for whom a surgery can be very safe and can cure their epilepsy. So someone who has a 1% chance of stopping seizures on medicines might have a 50 to 60%, or in some cases even an 80% chance of completely stopping their seizures forever with a surgery. So that's why we spend so much effort on it. It's a very long process of determining 2 main questions. The first question is there a surgery that would be helpful to this patient? Is there a surgery that we think would be very likely to stop the seizures? The second question, equally important, is would that surgery be safe? We would never recommend a surgery that we thought would affect someone's daily life, like their language or their memory or their ability to see or move their body. So we really make sure that the patients who are being recommended surgery know that it is a safe surgery with a very high chance of success.
And Dr. Martz, we have a question from Kathy. She says, my sister has had occasional seizures since 2014. Her body did the shaking, etc., but now the past few times it seems like her brain disconnects without the shaking. Is that considered epilepsy? Thank you, Kathy, for the question.
Yeah, that's a great question. It's very confusing for a lot of folks. Kind of what is a seizure? A seizure is basically an abnormal brain activity in any part of the brain. In many people, it starts in one particular spot of their brain and might spread a little bit. It might stay right in that one area, or it might spread to the whole brain. And the extent of spread affects how much of a seizure you're going to see that person having. So, for example, a very small seizure in an auditory or hearing area of the brain, the patient might experience that just as hearing a sound. That's not a hallucination. That's the seizure causing that sound to be experienced by the patient, but they might be fully awake and alert. If the seizure were to spread from that area to more of the the surrounding brain, it might affect their ability to speak, might affect their ability to interact with their environment. They may or may not be aware of what's going on, but maybe they can't relay that they understand anything. If it spreads to a bit more, it starts to affect what we call our networks of consciousness, so that we truly aren't aware of our environment, even if we're not showing any kind of shaking or seizing, sort of obvious seizing. And then if it spreads to enough of the brain, it starts to affect the motor pathways of the brain. That's when you start to see shaking and movement of the body. So anyone with epilepsy over time might have different levels of seizures. And what we see fairly frequently with someone with focal epilepsy is that when they start to come to the doctor, they might have just had a big seizure. It turns out in some cases, when we really talk to them carefully, they've had smaller seizures sometimes for years and just didn't know they were seizures because they were odd, like hearing a sound or seeing something in their vision. And when we start to treat people with big seizures, some of the time what we see is that the medicines stop the seizure spread before they stop the seizures from actually occurring. So what we see is instead of people having these large seizures, now they're still having some seizures, but they're staying in that small region of brain. Therefore, they're not having the big shaking episodes. And of course, our goal is to get them to stop the seizures completely.
Yeah, thanks, Kathy, for that question. So when a seizure spreads to another part of the brain, if you control that one part, let's say you control that part with medication, can it then spread since that part is controlled? How does it actually spread?
That's a great question, too. So the brain works at the sort of fundamental levels on what we call networks. So there's a connection between brain cells. Some people make comparisons to like a phone network throughout a city, for example. So you might have one part of the city that's not functioning correctly, and therefore you have to route through different ways, through different phone towers to get the call through. And so seizures can affect one part and cause what we call focal dysfunction in that one area. The seizure spread, though, if it's starting to spread, can take those normal cell towers, those normal brain cells or phone towers, and travel just like a normal impulse would. So since the brain is really geared to spread signals, the seizure can hijack that system and spread it to normal areas of brain, areas that wouldn't have any involvement in a seizure other than the fact that they're sort of innocent bystanders that get wrapped up because they're connected to that area.
So very important question for somebody like Kathy who has witnessed her sister having seizures, or anybody else who has witnessed a loved one or a friend or somebody having a seizure. What should that person do?
Yeah, that's important. So the main thing is to make sure that the patient is or the person, in this case your person who you love, is not being injured during their seizure. So that's the environment is the most dangerous part. And so what we want to do is avoid any dangerous things like sharp edges on furniture, or obviously if you're on a roadside or something, make sure they're not in traffic. So the first thing to do is kind of control the environment a little bit. You can do that by pushing furniture away, or if you need to, by kind of dragging the person a little bit away from whatever danger there is. If they're having a seizure that's violent and they're hitting their head in some way, you can't really control or stop a seizure by hugging or squeezing them, but you can minimize any injury. So the most common thing people might have is a purse or a sweatshirt or something. You can use those kinds of things to pad under their head if they're hitting their head on the ground. You want to make sure that you're reassuring. I know that you're probably terrified when you see these kinds of things happen, but you want to try to calm them. They may or may not be able to hear you, but it doesn't hurt. It certainly helps if they can hear you to be reassuring. If you need to get assistance, you can call 911 yourself, or you can ask someone else to call 911. Another question that always comes up is airway, or what's in their mouth. This myth that we try to make sure everyone knows is a myth of people swallowing their tongue. When someone has a seizure, the area, like a convulsive seizure where their body is shaking, the motor areas in the brain that control our muscles are involved in the seizure, and that's causing our muscles to contract very strongly. And that often includes our diaphragm, which is our breathing muscle, and that causes the diaphragm to lock up, and that looks like someone's choking. Their throat may also be locked up by the seizure, which also can make them look like they're choking. What's actually happening is just like everything else that's stiff in their body at that time in terms of all their muscles, their diaphragm's stiff, so they're not taking a breath. That makes often someone can turn a little bit blue as they're not getting quite enough air. Certainly that can be a medical emergency, but in nearly all seizures, which last typically around a minute, that seizure will end and then they'll immediately start breathing again. and it will recover. So the main thing to do is not put anything in their airway. Don't put a wallet or a spoon, or certainly not your hand or finger, because they can bite very hard during a seizure, and just let it pass. And there are times that people feel they need to give CPR during or right after a seizure. If someone really isn't breathing and isn't waking up, that may be necessary. Certainly in that scenario, calling 911 would be encouraged.
All important points to take note. I always like to end on a high note and talk about sort of the future in treatment for epilepsy. And right here at Hartford Hospital in the next few months, we'll be launching something exciting for monitoring and really pinpointing the area of the brain where these seizures are occurring, leading to a possible surgical solution. Talk a little bit about that.
Yeah, there's a number of surgical options, as I alluded to earlier, the most basic being to simply remove the part of brain that's causing the seizures. The other other types of surgery include implanting stimulating devices like a battery-powered electrode that can essentially try to see the seizures as they happen and stop them mid-seizure. So the key as these different treatments come out is determining which treatment is best for any one individual person. And the way to know that is to know the kind of epilepsy that they have and where those seizures are coming from within the brain. And what's very exciting is that we're on a verge of being able to provide a kind of intracranial EEG monitoring, which allows us to put electrodes inside the brain. This is a surgical procedure that's done by a very experienced, a highly trained surgeon at Hartford Hospital. And we then monitor the patient in our epilepsy monitoring unit, and we observe them having their seizures, and in this way can see exactly where their seizures are coming from. And once we've really pinpointed the exact onset of the seizure, then we can determine, could a surgery there stop those seizures? In addition, we do a variety of testing with the patient while they're in the hospital to determine whether that area of brain would be safe to damage or remove. In some cases, it is. And many times the area that's having seizures or starting seizures is an area that's not functioning normally even when it's not having a seizure, and therefore removing it doesn't cause any lasting problems for the person. If it was in an area that's very critical, like a language area or an area for memory or for moving your body part like your arm, then we would certainly not want to resect or damage or remove that part. But there are other treatments, like I mentioned, like stimulators that can be placed there. So we're very excited to be offering this kind of intracranial EEG in the near future. We'll be one of very few places in the state and really in New England that can offer that kind of service.
Looking forward to that. A lot of hope out there coming our way here in Connecticut. Dr. Gabriel Martz, thank you for spending your
pleasure.
time with us. This was an enlightening discussion, and I'm sure helped a lot of folks out there watching, so we thank you. And of course, as always, we thank you for watching. I'm Hartford Healthcare's Tina Verona. We'll see you soon.